Hello and welcome to Race and Health Matters, a podcast produced by the NHS Race and Health Observatory. I'm your host, Dr Guddi Singh. In this episode, we discuss lived experience and give voice to the realities faced by ethnic minority staff. We talk about structural barriers and organisational culture and how they shape pay outcomes and career progression and how this actually feels for ethnic minority staff. Well, look, welcome, ladies, to Race and Health Matters. Now, in this episode, we are starting with lived experience and with what the ethnicity pay and progression gap feels like from the inside and what that lived reality can tell us that actually the headline data is not able to tell us. Now, I'm so grateful to you both for joining us for this conversation. So I'm joined by Professor Doyin Atewologun, who's a psychologist, a scholar practitioner and a founder of and CEO of Delta, and Dr Nabeela Kajee, who is a medical doctor, health equity researcher and a consultant at Delta. So welcome.
Thank you.
Thank you. Great to be here.
And I want us to really kick off with this, I guess, the central question in this episode for me, which is that what does lived experience really reveal about the causes of the ethnicity pay and progression gap that data alone cannot answer and cannot show? So it's a very general question. I'm just going to throw it out there and then let's see where we go.
It's important for us to think about what lived experience is as a data source. And it may be worth listeners kind of just thinking through the ways in which, when people hear about lived experience, like how they compare that to other data points.
Yeah, maybe you could actually speak to why lived experience is actually important if we want to understand this properly.
Absolutely. So often, and I anticipate that many people listening to the podcast will kind of have a rough idea that when we think about research, there's broadly two buckets or categories. There's like quantitative, stats, patterns, like numerical, and then there is more narrative, more qualitative, more lived experience perspective. And when we think about the ways in which you understand complex, multifaceted phenomena, like how people show up as themselves when we think about issues of identity, but are faced with more kind of explicit or implicit barriers to their experience, to showing up authentically at work, because the answers to that question are quite complex and multifaceted. It is very important for us to understand the views, perspectives, ideas, experiences of individuals on the receiving end of these phenomena.
Yes.
And that is the key value of lived experience kind of research in the broader sense of just trying to understand the complexity of lives.
And I think it's important to establish that because so often in science, in general, quantitative is privileged over qualitative as a baseline.
Absolutely.
And then even within that, lived experience can sometimes feel like it's a throwaway thing that's kind of almost nodded to in healthcare settings, but not really respected in the same way. So, Doyin, just staying with you for a second, what do organizations miss if they privilege metrics over experience?
I've hinted at that. I think there is a nuance and complex and multifaceted understanding of the human experience in the workplace or, in society more broadly. And sometimes, particularly as humans, so as you said, I'm a psychologist, and we understand the bias of simplifying, a desire to just really understand, focus on like one key headline or story or perspective. And I think the value of lived experience, the importance of lived experience and the added value it brings is it brings alive in a very compelling way the complexities and the nuances of an individual's story. And that might involve things like how, for example, just as an example, how for me, maybe my experience as a Nigerian British woman working in a professional, kind of global professional context influences what it means for me to be seen as a leader, right? So immediately there are a number of intersecting factors, there are a number of explicit and implicit assumptions of what leadership and opportunity might look and feel like. And that complexity will not be captured solely by actually we've got one more X in a leadership role.
Yes. The stat doesn't tell you the real depth of what's going on there.
Absolutely.
And Nabeela, from your perspective, as a clinician and a researcher, what kinds of truths about the workplace become visible for you only when you attend seriously to that, well, to what people are saying who are actually experiencing it?
Thank you. Such a powerful question. I think we need to know what the numbers show. That's important. But equally, we need to understand the how, the when, and the why. And that comes from talking to people.
Surprise, surprise.
Exactly. It's not always easy, to ask people and to listen. But there's a lot to be learned from talking to people that are on the ground in healthcare in the UK and in the NHS. And I think that's the advantage of this piece of work.
I mean, I get it. I mentioned it before. I get the sense that lived experience is a bit of a trendy word and it's used a lot right now. I mean, there's lots of trendy words right now. Intersectionality, health inequalities, co-production, and lived experience is another one of those words that institutions particularly like to pretend they've got the badge on. We're doing it, guys. But they're not really doing it, right? And let me put it this way. They're not doing it to the extent that it's actually challenging the notion that the institution has of itself, right? So they're not actually inviting the truth, right? The depth of what could be said by those lived experience voices. And so I wondered whether you might be able to speak to a little bit about like what lived experience looks like when it's done badly and what does it look like when it's done well? Like when we actually engage with lived experience in a way that's how it's meant to be done.
When you ask about lived experience, what we're really asking is whose lived experience. And whose lived experience matters. And so really the instrument of gathering this research is the researcher. And as Doyin spoke to quite well, the researchers themselves bring a certain what we call worldview. Yeah. And myself as a medical doctor, as someone who is South African, living and working within the UK, similar to Doyin's story, we bring certain perspectives around internationalization, around healthcare in the global context, recruitment, thinking about how gender intersects with ethnicity, how other aspects of nationality, culture, language, etc., across also the protected characteristics. And there are many. Intersect with how we look at research. And so really intersectionality, having an appreciation for intersectionality in the deeper sense is so important in asking that question and really thinking about what we call lived experience, because if we can't appreciate the ways in which the different parts of that individual intersect, then we are only capturing a unidimensional picture. And I know, Doyin, intersectionality is your thing. It is our thing.
I thought it was Kimberly Crenshaw. Are you trying to own that now?
Not at all. Much respect to Kimberly Crenshaw.
Okay, got it.
Complete respect. But I'd love to pass to Doyin because I know that this is something that is deeply, deeply a part of the work that we do.
Yeah. So I think the question around what is good and bad lived experience is a very is a pertinent one. And permit me to maybe just kind of backtrack a little to just say a little bit about the history of lived experience.
Please do,
research,
yes, please.
Right? So lived experience research is like one of the ways in which many researchers in the social sciences, like it's one of the key methodologies, right? And this is because like back in the day, in the early days when people were studying like culture, so anthropologists, for example, it would typically be, right?
I think we've all got an image in mind. I think we've all got the same image in mind, right?
So someone would, venture and explore discover.
Pith helmet, khaki trousers. Yes,
a group
exactly.
of people who, had no understanding that they existed themselves.
No, totally. Right. And needed to be described.
Yes. Right? Would sit outside with their pen and paper, asking, measuring stick in hand, and make, informed notes about the other. Right?
Yes.
And so that it was so important when we think about the history of, kind of social science research for us to turn the gaze, or maybe not necessarily turn the gaze yet, but draw attention to the fact that the position of the individual who is putting themselves as the expert gazing and being they're holding a position of expertise with regards to telling that other story, that needed to be disrupted and dismantled. So it's about turning the gaze again, like going back to what you said, Nabeela, like whose lived experience, whose perspective is valued. But what I really love, just building on what Nabeela said, was because that kind of like going back to the history, again, anthropology or cultural studies, the assumption that this detached position gives you, a position of neutrality such that you can fully capture this other thing that you're observing has been challenged and moved us to a position where we acknowledge that both the observer, quote unquote, the researcher, and the quote unquote research, the subject, have a perspective in terms of how they're gathering data and telling this story, this truth or this version of truth. And so good lived experience research acknowledges that, mutual subjective, that idea that I am asking you questions from my perspective and my vantage point, and you're sharing, and I'm valuing your perspectives from your vantage point.
Yes.
I also wanted to add just one more thing, which is I think it is important for listeners to understand that there are frameworks, there are methodologies, there's systematic ways of conducting this research. It's not just, well, you know what, just get a bunch of people and just listen. Listening, of course, is the beginning, but we try to be very transparent with regards to the types of questions that we ask, the ways in which those questions are come from a body of maybe like I would say a body of literature that helps us decide what are some of the, I don't want to use the word hypothesis, but I'll use it because a lot of people will understand it. But, what are some of the things that we want to test and explore?
Yes.
And then we're quite systematic in terms of how we analyze the data, sometimes using an intersectional framework. And so there is a science to that as well. And I think that's another really key point when we think about the difference between good lived experience work and not so good lived experience work.
It makes me think so much of the biomedical gaze itself, right, which is all about neutrality and detachment and almost like an erasure of one's own positionality, right?
Clinical.
As if we don't come as human beings with bodies and histories and an interior psyche and all that, right? And so there are so many parallels, and I think maybe that's why in health settings it becomes double the problem, right? It's not just like the research framework. There's also that the way that we are trained as professionals even to view ourselves in that setting, which means that it's changing. But how many doctors were trained to really listen to that lived experience? So there's not just the history for data's sake, but the history for humanity's sake. And thank you. It's on that issue of humanity actually that I want to move us on, right? Because we're talking about some terms which might sound quite abstract actually when heard without understanding what this is. We talked about lived experience, but what we're really talking about actually is the ethnicity pay gap. So what does the ethnicity pay and progression gap feel like in ordinary professional life?
What does it feel like? I really love that question because I think, to your point about thinking about pay and progression, this research team itself constitutes people who are not just researchers but practitioners who've themselves been in the wards with patients. Many of us have researched patients directly and healthcare providers, so been at the forefront, not necessarily perched up in the ivory tower. And to that point of, sort of thinking about how it feels, I think for people who, researchers, healthcare practitioners, I speak from my vantage point as someone who has worked within healthcare systems, has felt what that means to be staring at progression and looking across the room and wondering, what is it that I'm seeing? And is it the same situation for everybody, or is this just my vantage point? And I think that's what I feel when I think about pay and progression is, what is the playing field?
Is it level?
Well, we are looking into that, aren't we just? Right? Mm-hmm. I think we all know that it's not. Mm-hmm. The question is, how is it not? And why is it not? And how might it be different?
Sure. Ask actually from an organisational psychology side what the impact is of this repeatedly looking across and seeing that the playing field is not in fact level. So in that under-recognised, under-appreciated, under-sponsored, being read as less ready. We're all brown women in this room. We understand what that means.
Yes.
Like, what is the impact of that happening repeatedly for organisations and for us psychologically?
Those are powerful words that you use, unrecognized, unappreciated, unseen, right? So, when we speak to individuals, it's not unusual, for example, for people to tell stories of, well, actually, I started my career or I started this job with the same person, with this other person, we started at the same level or the same role. But over the last few years, I've seen how this person is given opportunities, is granted, like other people talk about them and they're giving stretch tasks or, more highly visible work. And I'm asking myself questions about what else I need to do, why I'm not being invited to those rooms. So there's often a sense of just seeing people when we speak to them often play back that, over time, just that sense of being left behind, which for a number of individuals, it's one of those things where, like I just said, you see it in over time, and they haven't been able to put a name to it, to put a finger on it. In that moment, it's a accumulation of many, many really small, or maybe not small, but at that time potentially deemed innocuous or harmless, little micro,
everyday, right? The everyday microaggressions, right?
Absolutely. So on one hand, going back to your question in terms of what does that mean. From a psychological perspective, there is often a sense of, I would use that word again, that sense of invisibility, unseen, sometimes a sense of never being enough. Having said that, one of the things we find over and over again, not just with the within the NHS, but with other contexts, is that the reverse, being seen because you are in a small focus group with other people whose experiences are similar to yours. At that moment, there is often a sense of, oh my gosh, at least this, I'm not crazy. I'm not,
Yes.
this isn't,
Yes,
I'm just
absolutely.
imagining this.
Yes.
There's actually other people, so I am now validated, right?
Yeah.
I am the things I couldn't put my finger on, the
Yes.
things I couldn't, I thought, oh, right now. And potentially, if my organization or employer is taking this seriously, we are sharing these stories so that work and effort and resources will be committed to shifting this, and so it doesn't happen to the people coming after me.
Yes.
Many people listening and watching, they will say, well, oh, we know deeply. But this is the piece, is moving from anecdote to evidence. And that, I think, is the power of work like this, is to give anecdotes the opportunity to be measured and for us to see, well, how does this stand up to, how does the research hold up? Who, where, why, right? People are not all equal. Situations are not all equal. To have that sense of pragmatism, that we aren't just doing this to measure it for the sake of measuring it. So important.
Absolutely. One example comes to mind with one organization that we worked with, to just bring some of this alive a little. So we were working with it's in the private sector, a large organisation, and they had these headlines, i.e., for example, their minority ethnic staff were leaving at a higher rate, weren't progressing at the same rate, and they, so they had the headlines, but they wanted to understand what was going on, what the story was. And what we did was we worked with a number of individuals within their organisation using qualitative research with not just the minority ethnic colleagues, but their counterparts. So the early career white colleagues, for example, as well as the minority ethnic colleagues, the senior minority ethnic colleagues and the senior white colleagues. But we asked them the same question. So we have this method where we have a kind of a comparative process. And so we ask questions around like culture, what does it take to succeed around here? And one of the things that we found which was really quite powerful was everyone described the culture in a very similar way. This is a high-performing, where it's a really ambitious organization. We all need to kind of really work hard. We're proud to work here. But white colleagues, in addition to talking about that, talked about how much support they had in the everyday with the senior leaders to kind of reach out and say, you know what, don't worry, it's a late night, but hey, I'm going to order some pizza for you. I'm going to checking on you with regards to this kind of pizza project that you're working in. And minority ethnic colleagues did not have stories of support. So in that way, we were able to see with that example that actually there are two different sets of experiences in here beneath that headline to explain how, well, you know what, you get a bunch of talented people in here, regardless of their backgrounds. But what's happening for some people, they're getting all of the support they need, the social support, the encouragement, the nurturing. And for others, they're not. And I think that was a really for that organization, a really powerful way of showing how really understanding the vantage point of the lived experience.
And I think, that's a beautiful example of the value of lived experience, right?
Absolutely.
Which is not just identifying a problem, but then being able to get to the granularity of actually potentially even a solution there, right? Because you've identified what the mechanism is, at least in some regard, for one of the groups, right? To what's protective and what's really exposing the other group, right? And just to pick up on so many things that both of you have just said so wonderfully. First of all, it is an accumulation over time, right, of these small daily microaggressions, or just being, as we said, being under and unseen, right? Which on its own, that thing of not feeling like you belong.
Yeah, absolutely.
I mean, that on its own. None of us really grows up from being that kid at school who just wants to belong. Ultimately, I'm a pediatrician, of course. I look at it from that way. But that's ultimately what we're talking about. And institutions may step in if we are able to show the pay disparity, if we're able to show that there's stalled progression, potentially, because at least that's like something tangible. But they don't pick up on the fact that there's no belonging in a team, right? Or that some people are being sidelined, or there's some exclusion, right? And of course, we want to prevent. We don't want to have to just act at the end of a long line of misery. And I just wonder, how can we use lived experience to help raise that issue earlier as opposed to waiting?
I think it's so important to remember that behind all of these numbers are just real people that go home to their families every day. And these are the people that are driving our healthcare systems. I said to people in the room when we were starting this project that let's not forget these are the same healthcare workers that brought us through COVID-19.
Yes.
These are the same healthcare workers that put their own lives on the line every single day and continue to do so.
The same healthcare workers who are also not given PPE at the height of the pandemic.
Absolutely. And so there's so many reasons. To be supporting this workforce, to be protecting this workforce, to be ensuring that there's a fair chance to move forward in one's career, no matter what your occupation is within the NHS, to know that you have a place and that you have a sense of belonging and that you are here for the healthcare of the nation and the nation is here for you. And that is hopefully what this work will show, is that there's a chance for real change.
I'm interested in how this, the ethnicity pay gap and progression gap is material, of course, right? We're talking about money. We're talking about your ability to progress in your career. But of course, we've already just talked about the emotional toll, right? The thing that you come home with every evening. So it seems like you're suffering in two ways, right? Not only do you not feel like you belong, but actually, let's just face it, you're taking home less money to your family as you get there. But I imagine that a lot of our colleagues will not see it as their responsibility because they see it as a structural issue. And it's very easy when you say it's a structural problem, it's a system, to wash your hands of it. Even if you're, a well-intentioned manager or human resources person, whatever role you're taking. How do we bridge that gap from the individual responsibility and structural responsibility? Because, of course, we have different kinds of agency in this system.
Absolutely.
And I'm curious as to how you see that.
Yeah, well, we do a lot of work generally in terms of kind of developing leaders' capability to see their people and get the best out of their people. So, for example, we work with psychometrics to really help individuals in positions of power think through what are the specific behaviors that I'm engaging in that are contributing positively or not to the well-being and the performance of the people around me. So when we think about, there's, like you said, there's the sometimes if we think at systems at a level of, this is all one kind of big system I'm trapped in and I don't have much agency at one extreme, and the other extreme, it's like actually it's that person's every day, but these are like really tiny things and I can't catch them. I think people in positions of power, so for example, just to use general words like leaders or line managers, but of course those labels vary depending on the institution. I think there is a lot of evidence that actually says here's the set of behaviors that you can engage in yourself, whether at a level of actually what is my own what is my own like intrapersonal, what are some of the things I do individually in terms of, do I have courage, do I show humility, do I ask questions, what do I think, what are the things I do with other people in terms of like letting them know that I am kind of listening and responding to their needs. What am I doing with regards to the level of the team, i.e. do I have transparent processes where people understand how what needs to be done and people get a fair chance at those things, and do I stand for justice in terms of like championing fairness, championing inclusion. So I think I feel very strongly that there are many ways, for example, using tools like the tools that we use for individuals to actually say, this is the thing that I can do as someone in a position of power to disrupt these findings that we have. And it's just a matter of just doing. Like, I love what you said, like moving from, I said, anecdote to evidence and then impact. Like there's work, there's specific sets of behaviors that people can do.
I wondered whether you had any thoughts on that, because that's beautifully described, that we need to think about the different levels at which one can act. And you focus there on leaders because, of course, at some level, they should have more responsibility, right? But when you were talking, it struck me that we have this really strange way that responsibility falls out, right? Which is that on the one hand, we have those who are the victims, who have the responsibility almost to raise the flag and to fight the fight and to make the case and all the rest of it and to topple the system. Yeah. And on the other hand, you have the system itself, through the way that it suddenly becomes diffuse and abstract, washing its hands of it entirely. It's almost absolved of the problem, because it's almost like it's society, it's just the way that it works, or even to the fact, well, we don't see this as a problem, right? But again, like, how can we connect that individual agency to the structural problem, while fairly divvying out a responsibility, right?
You know, I think a lot of people who are listening will be thinking about exactly that, which is, how do we move into an action-based approach, a solution-based approach, and we don't get stuck in the problem itself, get tangled in the problem itself, right?
Yes.
And I think with the backgrounds that we have that intersect with research, clinical work, pragmatism, you know, even the consulting experience, being able to see the bigger problem solution network, you realize that, you know, we categorize some of these issues within what we call the wicked problems. So really difficult problems to solve, right? But that does not mean that they're not tackleable, that we can't solve them. And I think that's the piece that hopefully we can start to, you know, really get to with this work, is going into the specifics for what works, what does not work, why. And if we can understand the problem from an action-based perspective, recommending actions is easier. So I think it's a lot about how are we asking the questions, and are those questions being asked in a way that help us to find the solutions themselves. Because those solutions won't come from us as researchers. We will find those solutions from those that work amongst those problems.
I 100% believe you. And I believe that for all sorts of problems, whether it's race or not, actually, we need to ask people on the front line who are like literally at that friction point for what the solution should be. Again, not just professionals, our service users, patients, whoever, they might know the answer. But how do we find that out in institutions that are otherwise not listening, not looking, or overlooking, or, you know, like doing the show of listening and yet not really then acting? I mean, you're clearly an action-oriented person, right? You're talking about wanting to shift from that research to implementation, right?
Yeah.
But there's something here about what does it take to do that, right?
Yeah.
To really just, I think people like to commission research and they like to have reports on their table. Very rarely do we see that then translating into something tangibly different on the ground. And actually it comes to lived experience again. And I'm curious about this because I do a lot of co-production work, but what does it feel like for people to have been invited into a process to share their experience and then for them to see that little has changed as a result?
That's important because if we want to see translation, which is what you're saying, how do we go from point A to point B? How does the research get us there? We have to be able to use the tools available to find out what is necessary for us to solve the problem, not just to find out everything. Because I think this is the problem sometimes when we do research, is at the expense of finding the solution, we try and ask too many questions. Those questions are not targeted and not specific to the problem we are trying to solve. And I think in doing so, if we are able to move beyond and ask relevant, pertinent, pragmatic questions of those that are involved in this, the NHS workers, the health workforce, we won't be wasting time, wasting resources, eroding trust. We want to do the opposite. This is what this work is built on, the foundation of trust. That our team has got health professions workers, we have researchers, we have, you know, people who are on that front line who understand that. And I think that's the difference as well, is that the focus on this research is not simply to do a glossy report exercise, although, yes, we love a glossy report. It is to help inform policies. But the thing is, and I think you appreciate that, we appreciate this, that change is collaborative. We will need to have the buy-in, the hand-holding of politicians, of people on the ground to make the findings relevant.
Yes.
Right?
Yes, absolutely.
Whatever those findings might be.
And Doyin, why do you, or maybe you could speak to this question, which is like, why is there so often this disconnect between the leadership who are apparently listening
Yeah.
and the leadership who are actually, as Nabeela would have us have it, acting. Like, why is there that disconnect?
Why is there that dissonance or gap?
And what are your thoughts on that?
Yeah,
I know that you may not have the
indeed,
answer.
Sure.
Yeah.
Well, so I was thinking, as you know, as I was in the last few minutes, I've been having this conversation with one organization that we were working with. We kind of did the work, and then I went back to them because I was like, okay, so what's happened with the recommendations? Because we'd said to the people who'd told their stories, that they were going to act on the recommendations, and then the leaders were like, well, actually it was so rich, there was a lot in there, there are many recommendations, we don't know what to do, we're still thinking. And then I said, well, fair enough, but tell the people.
Yes.
Right. So I think that's
Yes.
the first thing in terms of actually going back out to say, thank you so much for the time you've taken. That work has been, your stories have been analysed, distilled, kind of have informed some practical recommendations. And what we're now going to do is we're going to take some time to reflect on or to prioritize which recommendations we're going to act on. That has more value than people thinking that this work has, I've committed, I've taken my time to tell my story and nothing is happening.
Yes.
However, what is the difference? And then, so that's one thing. I think when you say what is the difference between leaders who act and leaders who don't, leaders who do act are ones who are very intentional about sharing where they are in their journey to acting, rather than, what's that expression? Not quite hiding away, but kind of drawing away from the commitments that they made several months before then to do the work. One of the other things that we found, again, I think the three of us, this would resonate with us, that idea of like co-production, like essentially having providing fora that essentially are like, okay, these are some of the things that we're thinking about. Which of these, we might start with this because this is a quick win. We might start with that because, we've got resources. So let's work together with regards to which of these recommendations we're going to prioritize. And lastly, we don't do enough of this, organizations don't do this enough of this, evaluate the impact of the various recommendations.
Yes.
Nabeela was saying what's working, what's not working, and why. The only way we will get those answers is for us to have a reflective approach, like an approach to implementing action where we're like, what did we learn from having implemented those actions?
Yes.
And how would that improve? And what do we then, when we get the answer to those questions,
how do we then respond?
how do we then adjust the thing that we said we were doing? So there's an ongoing loop there, an ongoing process. And that's what I've seen is the difference between leaders. It's an ongoing process between leaders who are like, okay, I'm going to do something with this, and leaders who don't.
The reason I ask that question is because I feel that so often the language of justice is being absorbed by institutions in a way that sounds good on paper, but really is just preserving their elite comfort, right? And I say that knowing that there are many good people who are trying to change the system. I'm not saying that everyone is against social justice, but it is very easy now, I think, to use the right words and not actually translate that into genuine change. But what I keep hearing from both of you is that actually one of the key things that's missing here is actually a two-way conversation. So lived experience is one thing.
Yes.
But maybe the people who just gave you their experience want to hear back from you. And that's what I think you're saying, is that actually leaders need to not be so leadery. Right? And they need to actually be part of that co-production. It's not just about co-production from the ground up, actually.
Yes.
Come down.
It's grassroots.
Yes, and be part of that, getting messy and figuring it out. What are our priorities as a community, possibly, as opposed to as the NHS Trust. And that conversation, I think, doesn't happen anywhere near as frequently.
Absolutely.
And then, how could we facilitate that?
Yeah.
Can I build on that? So there's one project that comes to mind that Nabeela is very familiar with, where one of the things that's differentiating the leaders who, like you're saying, getting their hands dirty from other clients is a real sense of like personal commitment to this work and the change, the transformation we're working towards. A real sense of, actually, I am part of this institution, or I'm part of this profession, or I'm part of this community, and therefore I have a role to play, and I have access to power, resources, all of those other things. And I think to the extent to which people in power, or people who maybe belong to historically dominant, overrepresented groups, see that, I have skin in this game too. This is important for me and what I stand for as part of, what we're working towards. To the degree that happens, the change will come.
We've been talking around the ethnicity and progression gap, and I just wondered whether, again, you could just give us a little bit of context, like how big is this gap? What are we talking about here? Are we talking about like a crack in the pavement, or are we talking about the Grand Canyon? Like what's happening?
So I love that question, because that is like the headline question, and that's a statistical question.
Yeah, I mean, people want to know how bad is this?
Yes, so what we will be doing is and this is like, again, the value of like stats and headline data versus qualitative and lived experience. So the piece of work that we're doing is to explore the ways in which how people make sense of the gap rather than what the gap is. And so the quantitative team is going to provide all of the different kind of data points in the report with regards to the different patterns when we think about different occupational groups, or the different ways in which a range of different factors, such as where in the country you work, how long you've worked for, how that statistically explains or accounts for some of the gaps. Now, when we talk about how people make sense of the gap, just to go back to, how big that gap is. So what I'm struck by is the stories it's just to go back to something, Guddi, you said earlier, what is it like when people are just feeling this thing, right?
Yes.
Right? And the feelings, right? There are people in the NHS who've worked 40 years, and it feels, from some people, ginormous.
Yes.
Out of grasp.
Wow.
And one of the things that we've talked about is how important it is to acknowledge and appreciate the individuals who, despite the decades of who are coming with the decades of experience, who are still saying, you know what, the NHS isn't where I want it to be, but I'm going to contribute to this by telling my story. So it certainly felt deeply.
I mean, you just saying that. My father also worked for the NHS for 40 years.
Wow.
And I think did not get the recognition, appreciation when he finally retired, right? There was no sense in which there was any thank you, right? But it is what you said, right? These decades are not just decades of experience, they're decades of dedication.
Absolutely.
Right?
Absolutely.
People come to this work with so much honor and so much love and care for the professionalism that you need to bring to this job. And so I'm wondering if in your research, you're hearing that sense of betrayal when institutions do this, where they almost turn their back on you at these crux moments.
Yeah, it's an interesting thing to be a healthcare worker, and I'm sure people who work in health professions will relate to this, that we work in very tough conditions. We're trained to work in very tough conditions, right? This is the nature of the work, right? We withstand, we're resilient. Oftentimes, even going through, the COVID-19 pandemic, healthcare workers were characterized as heroic because of
a few claps,
the
didn't we?
degree. Yeah, a few claps.
Nice.
Yeah. the degree to which the commitment levels to show up to the jobs that we're talking about, right? To nurse people through illness, to prescribe and to witness illness in its most severe kind, to rehabilitate and provide physiotherapy for people that are incredibly injured and need to learn how to do everything from talk and walk again, right? These are the things we're talking about. And so to your question, when we abstract that of the level of, is there a sense of betrayal? I think there is so much more that we should be doing for health professions and for the workers in the NHS. And this is only one piece of that. And that is because that duty of care that healthcare workers are providing for their patients, the NHS is incumbent on providing to its workers. And so I think there is a much bigger question than betrayal, which is, do we care? Right?
Wow, yes.
Yeah.
That question haunts me because it doesn't feel like a healthcare system all of the time, right?
Yes.
Right?
Yes.
The example that comes to mind, oh gosh, just they're so powerful, the last few moments, is we heard, and there was a conversation recently around how a healthcare professional responds to a service user or a patient who is treating them quite badly,
yes, okay,
right? Who's
yes.
been racist or violent. And the response from someone who described herself as a nurse and who said, as a nurse, my commitment to the profession will trump the concern I have for the impact this is having on me.
Wow.
Absolutely.
Right? So going back to what we've been saying, that so if I am committing as a nurse to care for an individual who is treating me, who is potentially threatening and has a potentially there's a potential that they will harm me, right? Where do I get the care? It is hopefully from my colleagues, from my employer.
But is it there? I mean, what are you hearing?
We're here to study because we've been called to study, right? Like we've been called to this because there are concerns, real concerns. And I think this is something that, this work of the ethnicity pay and progression gap has been long pushed and pulled like a sack of potatoes by many people before us. And so we are here to do a piece of work.
Yes.
But actually this work has been building across not just healthcare, not just the NHS, countrywide by individuals who have championed the importance of a fair opportunity for people in their workplaces. That if you put the work in, you should move forward. You should not get stuck.
Yes.
You should not be held back.
Yes.
What is holding people back? And that is what is important, in terms of we need to carry the momentum and help healthcare workers where we can to have a fair chance at pay progression.
You're from South Africa.
Yes.
And it just struck me right now that if this was a country we were talking about that was treating a whole group of people so differently, there would be protests, there would be sanctions, there'd be embargoes. And I'm not saying that we need to do that at the NHS, but it's really interesting, isn't it? Like we put up with it in our workplaces.
Well, doctors are here striking, right?
Well, yes.
For pay.
Yes, for pay.
So
yes.
Not too far off.
Not too far off. But I mean, and it's not just race, right? There's a gender pay gap too. There's all sorts of gaps, right, that we tolerate.
Yeah.
And again, it just speaks to this idea that institutions have a very high tolerance for inequality.
Absolutely.
And again, how do we change that conversation? How do we start making it intolerable that this is happening? Just like eventually we were able to do in South Africa, right?
Yes.
Apartheid is not okay. So what do we do? How do we make it not okay that this gap exists anymore?
I think you're asking a question, which is, what is the straw that will break the camel's back?
Thank you. Yes. Right? You put it much better than I did.
How do we know? How do we, not at all, you did an excellent job. How do we actually get us there? And, I think something I want to say, because I think it speaks to that, is for the mum that is the nurse, and of course across professions, but the nurse that's going home every day and counting out the money and saying, you know what, sorry, actually this birthday we're going to have to skip it. There's no birthday present this year because you know what, we have to cover the groceries, we have to cover the rent. There's lots and lots of things that, you know, prices are going up, cost of living is high, you know, and, you know, it's pay gaps influence people very deeply. And when we start to think about it in terms of real applications of how that translates in people's lives, being able to offer their children quality education, being able to afford to retire, being able to access the same resources that others have access to in the work that you're doing, right? This is as much a dignity issue as it is an issue of values within the NHS, which is, are we going to act on the evidence to make this a fair place for the people that work here? And it's not a small number of people. It's a very large number of people. And so I think just decentering to your question around what would be that thing, I think, and of course there are many drops of water that build into an ocean, but I think something that is a big part of this is critical mass, which is, are the voices that are speaking the evidence to power, are those voices carrying? And this evidence is only as powerful as the people that are speaking it, that are using it, that are sharing it. And so, you know, from a research perspective, we have to do our best to communicate the work clearly and confidently around what we find in a way that is pragmatically useful. But we also need to be able to hand it to the people that can do something about that. Because voters are watching. Those that are in the NHS are watching. This is an issue as much as for our conversation as every other newspaper in the UK.
And I love that you look at your research in that lens, which is that it is for a purpose beyond the publication, beyond the, you know, even the results, right? It is, you've said repeatedly action, you've used pragmatic, like those are words that often researchers don't use, right? So it's so wonderful to see that it is oriented towards a goal and a philosophy beyond the research itself. And, you know, as we draw this to a close, I am very interested in action. I am interested in change. And I want to think about what, you know, you use that beautiful analogy of what is the straw that will break this camel's back. Let's talk to the camel, right? So now let's imagine that the NHS leaders are listening to you right now, which they might be. Are you listening?
We hope so.
Let's imagine they genuinely want to act, right? So they're people who actually want to make that change. Where should they start, Doyin?
I'm going to try to be both abstract because there are many, many, many scenarios and specific.
Well, so one model I use with in workshops is to talk about a baby step you can take, and also the big power shift. So you can give something that's like, oh, you can do that tomorrow, and then also be like, here's my blue sky, like I want the world to change.
So I think the first thing, which is before, you know, those specifics, is what is my sphere of power, whatever it is. How much power do I have? What is my source of power, agency, resources? I think that is important. And within that, so that's why I said, like, you know, at the beginning, you'd need to kind of I need to be a little more abstract, like just figure out, like, what power do I have?
Yeah, love that question.
Because just to kind of build on what Nabeela was saying, you know, in answer to your question, things will shift when people with power intervene and shift things. Right. So figure out but we all have power in different ways, right? So that's the first piece. And then to go back to your, like, what is a baby step versus what is a big thing? A baby step, particularly if you have power, is get as many other people who have power on side.
That's a great one, yes.
Use it. Use your power.
Beautiful, I love that.
Right?
But also because you're talking about collectively taking action, right? There's no hero in this, right?
Absolutely. And collectively, I mean, we know from the research that actually if I'm speaking to, let's just say, an older white man about why this is important. he's more likely to have his eyes glaze over. Well, actually, this is who she is. She's a little activist. She's got a chip on her shoulder.
Yeah.
If another white man is like, you know what, hey, bro, let's kind of like have a cigar and talk in the old boys club. This is important.
Yeah.
That's much more likely to have impact.
This is allyship, though, right? That active allyship.
It is. And so there's allyship, which is I'm going to advocate for that group. And then there is I am going to talk frankly to someone who sees me as,
One of them.
as one of them,
Right.
about why this is important for us.
Brilliant. Yes.
For us.
Brilliant.
Right. So we need to move away from, this is the thing for them. We're doing it, like benevolently.
Interesting. Yes.
This is the thing we need to do for us.
Wow.
Whatever that us is, or whatever that kind of, again, sphere of kind of power or influence is. So for me, that's the first action. Get as many people, speak to your people and get them on side. More blue sky is along the lines of investigate within your domain, whatever that is, whether that's your team, whether that's your department, whether that's your institution, whether that is your country. What are the policies? What are the things that we do? What are the things that we do that have a differential impact on different people? So whether that is at a very simple level, many people will be familiar with actually what our promotion process is, whatever that is, that promotion process, what is happening there?
Yes.
Right? Such that some people have greater access to positive outcomes and other people don't. And change it.
Yes.
Change it. I know there are many, 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 many different ways in which you can change it. That is it. So first is get your people with power.
Yes, love
and
it.
the second is evaluate your policies or practices and just focus on one. Just focus on one. I'm going to end this bit with, I've had so many people like, okay, just tell me, what should I do? What is the thing we should do? Tell us what to do. And I'm like, just pick one thing. It doesn't matter. Just do one thing. Do it consistently.
Yeah.
Wake up tomorrow and say, this thing that I'm going to do, I am going to do it every day.
Yeah.
And when you do it, teach other people to do it. Right? And when other people don't, teach them to teach other people to do it. It doesn't matter. I don't care what you do. Because there's so many things you can do.
Yes.
Pick one and be consistent.
Wow, powerful. That's a great message. Nabeela, you also have the ear now of every NHS leader.
Yeah. Oh, and you know what? Tag them if they're not listening. We want them to listen, right?
So what should they hear from you about how we're going to tackle this?
This is an NHS of many languages, of many national anthems, of many people, right? People that come with many different lived realities, but should come to an NHS where they're all able to progress.
Yeah.
And I hope that the work of looking at the pay and progression gap across ethnicities help the NHS to take a very close look at what's happening on the ground and take that evidence and use it. That's all.
Yeah, because we talk about a rainbow NHS, right? But is that rainbow shining brightly right now or not? I mean, it isn't, right? And this conversation has been so wonderful. Thank you so much for sharing your expertise, your passion. But it leaves me with this idea that there's, the ethnicity pay and progression gap is not a workforce anomaly, right? It's a symptom of a deeper disease, right?
Absolutely.
It's a moral signal about what we value, who we value, trust, authority, what is possible for certain people in our society, and how that is distributed within an institution. And so it is a sign that things need to change. It's what you said, pick something and change it. And so it's like an early warning system, right?
Yes.
Listen to it because the system is in danger. And I wonder whether that's something else that comes out of it, which is
Absolutely.
This is not something that we can ignore.
This is precious to us.
Yeah.
The NHS is precious. And I think it's something that we can all be incredibly proud of, right? But it also is something that is not guaranteed. And we know that. And so we have to protect the people that are holding up the walls of the NHS.
Yes.
Yeah.
Well, on that very powerful point, I'm going to draw this to a close. Thank you so much, ladies. That was
Thank
fantastic
you.
conversation.
Thank you so much.
Thank you. No, thank you.